Welcome to AETCM. My name is Matthew Vincent and I am currently doing my house agency in Amrita Institute of Medical Sciences. So today we will be discussing how to present a general medicine case from the point of view of an MBBS student. So let's start. My patient was admitted here on the 25th of February and was examined on the 3rd of March 2020. His chief complaints include distension of the abdomen and swelling of both his lower limbs for 2 months, fever with diarrhea for 2 days, and altered consciousness for a single day. The history of presenting illness indicates that the patient, who was apparently normal 2 months back, developed distension of the abdomen, which was insidious in onset and slowly progressive in nature. It increased over the past 1 month, but later reduced following treatment. There have been no aggravating or relieving factors. There was no associated abdominal pain, constipation, diarrhea, dark colored stools or vomiting of blood. He also developed a swelling in both his lower limbs along with that, which was also insidious in onset and slowly progressive in nature. It extended from the knee downwards and he started developing pain after 3 weeks. The swelling increases after walking and he also complains of discoloration and thickening of the skin below the knee. It was associated with a history of yellowish discoloration of urine for the same period. There have been no burning, micturition, frothing of urine or any difficulty in passing urine. There is no history of breathlessness, pain in the abdomen, loss of consciousness, palpitations, chest pain or cough during this period. The patient gives history of fever for 2 days, which was acute in onset and was associated with chills. There was no evening rise of temperature, no night sweats or any diurnal variation. It was intermittent in nature but cannot be properly assessed since the patient was taking paracetamol. There have been no aggravating or relieving factors. The patient also had 3 episodes of diarrhea since the 2nd day of fever. It was watery in nature, not blood-stained. There was no vomiting, abdominal pain, cough, breathlessness, palpitations, neck pain, headache, rashes, burning, micturition, loss of weight or use of any other medications during this period. The next day, the patient passed stools involuntarily and he was also drowsy and appeared very confused. He was not responding to directions or speaking properly. There was no loss of consciousness, but he was unable to walk properly. The patient was taken to the hospital and admitted in the ICU. Subsequently, he improved. Now coming to the past history, the patient was diagnosed with a liver disease 2 years back. There was no history of diabetes mellitus, systemic hypertension, dyslipidemia, cardiac disorders, tuberculosis or asthma. The surgical history shows an appendicectomy that was done at 15 years of age. The personal history indicates that the patient had a veg diet. His appetite has reduced over the past 2 months. He has reduced sleep at night and sleeps more during the day. His bowel and bladder habits are as mentioned. The smoking history shows 3 cigarettes per day for the past 20 years till 2 years back, giving a pack year of 3. Alcohol consumption was around 5 to 6 packs per day from the age of 30. Family history indicates that his mother had systemic hypertension and his father died due to a myocardial infarction. He has an allergic history to NSAIDs, sulfur drugs as well as penicillin. There is no significant drug history. Now let us start off with the examination. The general examination of the patient shows that he was drowsy but arousable. He had a height of 170 centimeters and a weight of 90 kg, but the BMI could not be calculated properly. He seemed well built and nourished. His vitals were BP of 100/60 millimeters of mercury taken from the right arm in supine position using the adult size cuff, a pulse rate of 84 per minute with a normal rhythm, character, volume, condition of vessel wall. There was no radioradial or radiofemoral delay and all the peripheral pulsations were felt normally. The respiratory rate was 18 per minute and was abdominothoracic in nature. He had a temperature of 98.4 degrees Fahrenheit. There was no pallor, cyanosis, lymphadenopathy. Icterus was present in the lower palpebral conjunctiva. Clubbing grade 2 was present and bilateral pitting pedal edema was also present. The head-to-foot examination indicates that the patient had a right-sided parotid swelling. There was loss of axillary as well as pubic hair, gynecomastia, spider nevi present over the upper chest, ecchymotic patches, 2 on the left arm and 4 on the right arm. The abdomen appeared distended with stretch marks. The appendicectomy scar of 7 cm over the right iliac fossa, and there was also discoloration of the leg present. Flapping tremor was also demonstrated. Now let us begin with the examination of the gastrointestinal system. The oral cavity showed normal lips, teeth, cheeks, tongue, palate, floor of the mouth, mucosa, tonsils as well as pharyngeal wall. The examination of the abdomen. Inspection showed that the abdomen appeared distended, the flanks were full, they had normal movements with respiration, no visible peristalsis and no dilated veins, the umbilicus was midline and inverted, appendicectomy scar like described, the hernial orifices were normal and there was no divarication of recti. The palpation showed that the abdomen was soft with no tenderness or local rise of temperature, no hepatic or splenic enlargement and no renal angle tenderness. The percussion showed a liver span of 13 centimeters, which was felt from the right fifth intercostal space downwards. Tidal percussion was done and was normal. Shifting dullness was present and fluid thrill was absent. The auscultation showed abdominal sounds of 2 per minute. The external genitalia was examined and testicular atrophy was noted. Rectal examination was not done. Now moving on to the examination of the nervous system. The higher mental functions of the patient show that the patient was a right-handed person, was drowsy but arousable. His recent, remote as well as immediate memory was intact. He was oriented to time, place and person. He had no delusions, hallucinations or illusions. His intelligence was normal, speech had a normal fluency and his language was also normal. The cranial nerves, the olfactory was normal on both sides, optic with a visual acuity of 6/6 on both sides, visual field was normal along with color vision on both sides. The oculomotor trochlear and abducens nerves show that they had no problem with regard to nystagmus, squint, diplopia, ptosis. The pupils were shaped normally and the accommodation reflex, both direct and indirect, were normal on both sides. Trigeminal with the motor as well as the sensory parts were normal, and the reflexes like corneal and conjunctival were normal on both sides. Jaw jerk was absent. Facial with the wrinkling of forehead, nasolabial fold, puffing of cheeks, orbicularis oculi, deviation of the angle of mouth were all normal. There was no deviation. The platysma was normal. The taste sensation on the anterior two-third of the tongue was also normal. Vestibulocochlear nerve was normal and equal on both sides. Vagus and the glossopharyngeal showed no nasal twang, no nasal regurgitation, no drooling of saliva or dysphagia. Gag reflex was normal, and the position of the uvula and the palatal arches were also normal. The spinal axillary nerve with regard to the sternocleidomastoid as well as the trapezius was normal on both sides. And the hypoglossal nerve showed no wasting of fasciculations of the tongue. The movements of the tongue and the power was normal and there was no deviation. The taste sensation on the posterior one-third of the tongue was also normal. The motor system showed bulk which was equal on both sides in the mid-arm, mid-forearm, mid-thigh and the mid-leg. The tone was normal and equal on both sides. The power of the muscles in the joints, that is shoulder, elbow, wrist, hip, knee and ankle, were normal and 5/5 on both sides. The reflexes, the deep tendon reflexes, jaw jerk was absent. Biceps, triceps, supinata, angle as well as the knee were normal and equal on both sides. The superficial reflexes, that is abdominal and cremasteric, was normal on both sides, and plantar was plantar flexion on both sides. The sensory system with regard to touch, that was fine touch as well as crude touch. Pain, that is superficial as well as deep pain. Temperature, both hot and cold. Vibration sense as well as position sense was normal in both sides with regard to the face, trunk, upper as well as the lower limbs. Cortical functions that include two-point discrimination, graphesthesia, stereognosis, tactile localization and sensory inattention was normal on both sides. The cerebellar functions showed no nystagmus, cystokinesia, no scanning or staccato speech. The finger, nose, heel, shin as well as a straight line test were normal. There was no rebound phenomena and the patellar knee jerk was absent. Gait was normal. There were no signs of meningeal irritation like neck rigidity, and the Brudzinski's as well as the Koenig's test were normal. The peripheral nerves showed no thickening and there were no skull or spine deformities. Examination of the cardiovascular system. Examination of the chest showed, with the inspection appearing normal, appeared bilaterally symmetrical. There was no precordial bulge, the apex beat was not visible, there were no dilated veins or any scars, and no other abnormalities. The palpation showed no local rise of temperature or tenderness, no left parasternal heave, no thrill, and no epigastric pulsations, and the percussion showed the cardiac borders normally. Auscultation showed S1 and S2 heard normally in all the 4 areas with no added sounds. Examination of the respiratory system. First, with the upper respiratory system. It showed a normal nasal cavity with no deviated nasal septum, no nasal discharge. The sinuses appeared normal and there was no postnasal drip. Examination of the chest. Inspection showed trachea that was central, shape of the chest that was normal with no kyphosis or scoliosis, normal movements with respiration which were symmetrical in nature. The apex beat was not visible. There was no drooping of shoulders, infraclavicular wasting or supraclavicular hollowing. Palpation confirmed that the trachea was central in nature. There was no local rise of temperature or any tenderness. The apex beat was felt in the 5th left intercostal space 1 cm medial to the midclavicular line. Chest measurements with the AP of 25 cm and transverse of 30 cm. Chest expansion of 3 cm equal on both sides and a chest circumference of 44 cm on each hemithorax, together 88 cm. Chest movements were normal and vocal fremitus was normal and equal on both sides. Percussion was bilaterally resonant in all the areas, and the upper border of the liver dullness, as mentioned, was felt in the 5th right intercostal space in the midclavicular line. Auscultation showed normal vesicular breath sounds heard in all the areas. There were no added sounds, and the vocal resonance was normal in all the areas bilaterally. So that brings us an end to the examination. To summarize, my patient is a 41-year-old male with complaints of distension of the abdomen and swelling of the lower limbs up to the knee for 2 months, fever with diarrhea and yellowish discoloration of urine, the fever and diarrhea present for 2 days, as well as altered consciousness for a day. He had a history of appendicectomy at 15 years of age and a diagnosed liver disease since 2 years, as well as history of chronic alcohol consumption. On examination, icterus, clubbing, bilateral pitting pedal edema, right-sided parotid swelling, gynecomastia, spider nevi, flapping tremor, shifting dullness, and testicular atrophy was noted. Other systems were within normal limits. Coming to a provisional diagnosis, this could probably be a decompensated chronic liver disease with features of hepatic encephalopathy. So that brings us to the end of the case presentation with regard to the gastrointestinal system. Thank you.